Good afternoon and warm welcome to the Department of General Surgery. I am Dr. Ramesh, Associate Professor of General Surgery. Somehow we have met with, unfortunately, we have met with, because of this lockdown, online classes. And today we will try to learn something about chest injuries, trauma to the chest. Before going to the topic itself, I would like to just mention a few things about trauma. You might be knowing what trauma is. Trauma is a Greek word. Basically, it is a Greek word, which means that trauma is nothing but a wound. And most of the wounds, though simple in nature, you should be thinking of polytrauma. That is, multiple systems are getting involved, not only chest, but maybe abdomen, or maybe pelvis, maybe extremities, or maybe in the central nervous system, along with the spine. So we have to think and assess the patient accordingly. And the two important things I would like to mention here is, one is chest injuries per se is an important question. It come as a long question, and some parts of the chest injuries, they can come as short questions as well. And before going to the topic, I would like to just give you an idea about trauma in its broad spectrum. Never underestimate trauma, because those patients, trauma is one of the major causes of the death in the patients, reaching those who are lucky to reach the hospitals. And in about 42% of the cases, that is basically because of brain injury, there is CNS involvement. Almost approximately about 40% is about chest and abdomen. That is torso injuries. We call it torso injuries because we read anatomy but not the injuries. So we can discriminate something like chest or thorax from the abdomen, from the pelvis, likewise, from the extremity. But in about 40% of the cases, ultimately death results from the torso extremities that combines both the chest as well as abdomen and the pelvis, along with its structures. And major component of the death in these cases is hemorrhage, that is bleeding. So aim is to stop and control the bleeding. And before doing that, we should always assess the patient as a whole in the emergency department, or you can call it as casualty, and whether the patient is conscious, coherent, and we go for a primary survey, we go for an inspection and examination of the patient according to ATLS core guidelines, that is advanced trauma and life support, and we go for primary survey of the patient. Primary survey is something which is very important, because don't go on examining all the injuries to the patient, but the essentials you will be examining. That is, in the primary survey, you will be examining ABC. Of course, you can call it an extensive ABCDE. And this E is something like external hemorrhage, which is critically obvious. That means there may be injury, there may be torrential bleeding coming from the scalp, or coming somewhere near the extremities. So you have to control simultaneously this external hemorrhage according to A means airway, B means breathing, C means circular, D stands for visibility, and E stands for environment or exposure of the patient to the environment. So this is what most important, because this ABCs can lose your patient immediately without giving much time to you. So this is a lethal complication, and these lethal complications must be avoided by doing a primary surgery. That is A, B, C, D, E. Whenever you suspect the patient to be having head injury, suppose head injury, there are different scoring systems for different systems. But in case of polytrauma, it's not only one system, as I have mentioned before, but it is different systems that ultimately culminate and that ultimately lead to the fatality of the patient. That is, when coming to the CNS, we take the score of this, that is Glasgow Coma scale, we say it. This we will come into the details when we, or some of the colleagues, will be discussing about the brain injury. But in a nutshell, I will mention you. It is BCS score is maximum up to 15. With EMG scoring. That is, E stands for eye opening, M stands for motor response, and V stands for verbal response. And eye opening, you score it as a 4, maximum of 4, motor response maximum of 6, and verbal response maximum of 5. So total make it as 15, and 15 of 15 is normal, and 3 of 15 is dysfunctional. That is, the patient is no more with you. So eye opening, if it is spontaneous, we call it as 5, 4. Sorry. Eye opening spontaneous is called 4. So if you give a painful stimulus and then only eye opening is there, you can call it as eye opening 3. I mean, eye opening 3 is the speech, eye opening 4 is spontaneous, eye opening to speech is 3, and only the painful stimulus is 2, and nil eye opening or no eye opening is 1. This is about eye opening. And motor response is maximum score of 6 is given if he is able to obey your commands. And 5 is given, motor response of 5 is given. Motor response 6 if he obeys commands. If he localizes to the pain, score of 5 is given, and score of 4 is given if there is flexion to the stimulus is there, and if the flexion is abnormal, score of 3 is given, and if there is extensor response, score of 2 is given, and no movement at all, no elicited motor movement, score of 1 is given. This is called motor scoring, motor system response. And finally, the verbal score. If he is able to well oriented and in conversation too, 5 score is given, and verbal commands to speech 4, to painful stimulus 3. Likewise, if you scoring, you have 15 of 15, there is a normal score in case of GCS. This is something different from Glasgow outcome score, where will be called GOS. These things will be discussed later when we come something about to the topic of the brain and injuries to the brain. An important concept that you have to understand, one has to understand is when you are dealing with a case of chest injuries or abdominal injuries. And in fact, when coming to that point, when coming whatever polytrauma you are dealing with, you should be dealing essentially with whether you are going to deal the patient after the primary survey is over and you have excluded the major injuries like airway, breathing, and you have attended the circulatory system, and you have pinpointedly identified whatever the disability is there, like focal neurological deficits, and you go for a secondary survey. And what are all the injuries that is top to the toe are there. And in cases when the patient is intubated and you cannot go for secondary survey, and ultimately you can go into tertiary survey once the patient comes out of the tube or extubated. That's what we call tertiary survey. And in these cases, we would like to see whether it is we go for elective total care or damage control care. Elective total care and damage control care. We choose the concept of damage control care because our DCS means damage control surgery. Damage control surgery because a patient who is already moribund, who is already physiologically compromised, may not withstand a complex procedure anymore because he is not only injured physically, that assault, the physical assault is being causing physiological and immunological disturbances, so that recovery might not be good, and ultimately that might invite what we call triad of death. That is, the patient may go into hypothermia, the patient may go into hypothermia and coagulopathy. The patient may go into hypothermia and coagulopathy, inviting further acidosis, usually metabolic. Of course, sometimes respiratory acidosis may also be there. So these all these things will go into, will lead the patient to multi-organ function dysfunction and ultimately leading to the death of the patient. So whatever is required, we do that on an emergency basis. And once the patient gets stabilized, we can go for a definitive correction of whatever deformities are there, whatever fractures are there, or whatever compartment syndrome is there. Like this. Suppose if the patient is having something wrong within the abdomen, like there is LV bleeding, yes, we can go for rapid laparotomy, and we can go for rapid control of hemorrhage, that means bleeding, and we put some packs, and whether there is any vegetable fibers are there or fecal matter is there, we try to decompress them, we try to remove them and decompress the abdominal cavity. And in case of orthopedics, something like there is massive fractures, we go for thorough decontamination of the wound, and at least temporary splintage of the wounds. Likewise, once the patient has been recovered physiologically, the important parameters all thing is the patient once comes out of the shock, that means BP getting normal, pulse rate getting normal, and respiratory rate getting normal, and he is not on acidosis, like we call the blood gas analysis is there, the dark gas analysis is there, and his coagulopathy has been rectified, or normal coagulation cascade systems is there. So that is complementary systems will not get activated once you put your knife under the anesthesia. And important biological markers being normal, like serum lactate, venous lactate, we call it. This is very important landmark. The venous lactate levels, so patient's venous lactate levels should come ideally below 2 micromoles per liter. If it is between 2 to 5, we go for resuscitation, and if it is more than 5, we go for damage control surgery. There is no option left over. And coming to chest injuries now, as I said before, chest injuries alone may or may not be there. It is associated with other injuries as well. And one that entity is called torso injuries. So neck is different from chest, is different from abdomen, is different from pelvis, is different from extremities. This is all anatomy, but injuries do not read anatomy. Remember that. And when we come to chest injuries, but as I said before, it is a multi-system disciplinary system. Multi-system injuries might be there, but let us think that let us separate for a component by component. And so, what are the important components of the chest? So, whenever there is injury getting transmitted from one anatomical region to the another anatomical region, traversing or making its force, because the concept of definition of trauma is a physical assault or physical injury that is caused by a physical agent to a patient is called as a trauma. And when we speak about this trauma, the physical agent may be chemical, or the physical agent may be some sort of ionizing radiation, or physical agent, unless mentioned otherwise, it is usually mechanical. And mechanical energy always takes its source from the site of its impact through your anatomical zones and ultimately leading to some other injury. That's what we call its transverse to the anatomical junction. So what are the important anatomical junctions is root of the neck. And as far as root of the neck is concerned, any injury that is causing injury to the base of the neck can also cause a hematoma may be there, or important vascular structures that are contained within the root of the neck may get injured, and that is causing root of the neck injuries. Because it is the one, root of the neck is the one which ultimately leads into thoracic inlet. So, root of the neck ultimately leads into thoracic inlet, and there lies the mediastinum. So, any injury to the mediastinum, important vascular structures are there along with the heart, and even when the patient is clinically settled, there are no profound features like shock. So one should always be careful when you try to identify, when you have identified contusion injuries or the chest wall or mediastinal injuries. You should be careful, be alert bit about heart and iliac. And third thing is the diaphragm. This is the part, the smooth muscular part that separates thoracic cavity from the abdominal cavity. But you all know that it aids in respiration, active movements of respiration, And important thing is it goes on constantly moving from somewhere around 50 to 8 intercostal space. So any injury to the diaphragm should lead to the suspicion that there might be some intra-abdominal injury as well, or thoracic injury might be extending into the abdominal cavity injury as well. This is the important point about diaphragm, because whenever there is a penetrating injury coming to your fourth, below the fourth, I mean fifth to eighth intercostal space, there will be injury to both the lungs as well as the abdominal content. And always remember that thoracic cavity lies in the negative pressure and abdominal cavity lies in the positive pressure, and the contents may extrude through the diaphragm or the injured diaphragm from the abdominal cavity into the thoracic cavity and complicating the picture furthermore. And fourth thing is, of course, abdominal cavity and the pelvis. Abdominal cavity, there may be on the right side, there may be injury to the liver, left side there may be injury to spleen, retroperitoneal structures will be there. Your thoracic aorta part that might descend in the aorta, that might get injured. And ultimately coming to the pelvis, pelvic injuries are a bit complicated in a sense that they are direct end branches of the aorta. They can profusely and torrentially bleed, and the bleeding is very difficult to control at times because arterial inflow has to be controlled along with the venous outflow. So, which is technically difficult, and we can ultimately go into probably arterioembolization, which may be useful in case of these pelvic injuries. So, as I mentioned before, almost all the injuries, about in 40% of the major morbidity, major mortality that is being contributed by thoracic injuries. So our concept is thoracic injuries now. Thoracic injuries, and 25% of those injuries, all the injuries, that is somehow related to thoracic injuries, and another 25% of injuries as a whole, they contribute to increase the mortality of these patients. So roughly about 50% of the patients of polytrauma cases, they sustain these sort of injuries, and out of which, if you look at them carefully, 80% of them, they can go home without surgery, only on conservative basis. So the important thing is you should be having a high degree of suspicion. High index of suspicion is important. And as in any case of bleeding, you should monitor the signs of bleeding. Like, there is increased pulse rate. In case of lung systems, there will be increased respiratory rate. There will be increased blood pressure. There will output monitoring you should be doing. It should be, ideally, it should be more than 30 to 40 milliliters per hour. And in this case, all the features of shock will be there, right? Like the neck veins or collapse neck veins, all these things, depending on the situation. So you have to be careful about this bleeding, and along with the coagulation profile, along with the acidosis, and along with the poor body temperature. And mentioning all these things in a nutshell, we will try to discuss about the investigations. Directly, why I am jumping to the investigations? Because in a casualty setup, you are seeing the patient, you are watching the patient. Probably this could be the diagnosis. You have to, after inspection and examination, you should come to the proper diagnosis. And investigations might be helpful to come to a provisional diagnosis, because it is always overriding the physiological stability is more important. And once you have done resuscitation, physiological, after inspection and proper examination, and probably not much time will be there to seek all the history. Of course, if patient is stable, you can take history from him, or from a reliable attendant, you can take history. And in most of the cases associated with head injury, taking history is also may get complicated because of the influence of the drugs or influence of alcohol, or with confused patient, or cyanotic patient, or agitated patient, or irritable, restless. All these things may not give you proper history. So some of things, the fundamental thing is chest X-ray. Chest X-ray may be useful. And before coming to the chest X-ray, I would like to specifically tell about ultrasound. This is something different from what we call EFAS, that is extended focus assessment. Extended focus assessment by sonar, by sonar for trauma, by sonar for trauma. It is extended. We call it as extended because it specifically EFOST. This is a potentially bedside investigation. While the resuscitation process is going on, you can go for this investigation, and this is focused assessment of for sonar, focused assessment by sonar for trauma. So it is easily reproducible. It is a bedside investigation. It is cheap and reasonably reliable investigation. Though some pitfalls are there, we will come to that later, time permits. And this can detect whether there is actually patient is bleeding or not. So anything that is more than 100 milliliters of blood, yes, or you can detect through the scan compared to the chest X-ray, where there is probably more than 300 ml of blood should be accumulated in the abdominal cavity to under the diaphragms to know that there is hemoperitoneum. But more than 100 ml, yes, you can detect. Any collection in the pericardial sac, yes, it can detect. And any contusions in the lung, it's probably going to detect. And any collection in the abdominal cavity, right paracardic or left paracardic gutter, or something under the diaphragm or in the pelvis, all these things can be detected, and this scan gives you a clue. And coming to the fundamental investigation, that is chest X-ray, that I have just started telling you. This chest X-ray, or this gives you, yes, in case of unstable patient, it is a bedside investigation. It can be easily carried out. No help for the radiologist. You can assess X-ray by yourself, and you can identify in a patient who is hemodynamically unstable and irritable. Because of the irritability, he might not be cooperative as well. You can find out whether there is any tracheal deviation either. In case of blunt trauma, things will be different in case of compared to the penetrating trauma. In case of blunt trauma, whether there are any skeletal injuries associated with any pneumothorax or any hemothorax, along with, of course, any highly unlikely to diagnose something like herniation of the contents through the diaphragm from the abdomen into the chest cavity. But these structures can potentially give you a clue, because whenever there is, you can find out fracture on the chest X-ray. If you find a fracture in the thoracic inlet, somewhere in the near thoracic inlet or thoracic vertebrae, or there is a bilateral clavicular fracture is there, or there is a fracture of scapula, or there is a fracture of sternum, or there is a fracture of at the root of the neck. All these give you clue that your thoracic, the patient's thoracic may be at the risk, Whereas fracture of the lower vertebrae may be giving you a clue that liver on the right side and spleen on the left side may be at stake. And forget about the fracture of the higher vertebrae or lower vertebrae, fracture of the vertebral system at anywhere from the T1 to B12. Obviously, it might give you a clue that lungs may get injured, might have got injured at that time, leading to contusions or hemothorax or pneumothorax. And in case of bronch abnormalities, as I mentioned before, tracheal deviation can also be made out in the chest X-ray. And in case of penetrating injuries, this is not of much use. In case of hemodynamically stable patient, of course, it can be of some use, because you can ask for an X-ray in the erect posture rather than the supine position. So in the erect posture, you can see excellently whether there is pneumothorax or air fluid levels are there, whether there is fluid meniscus is there, whether there is any fluid meniscus is there, and in case of whether there is any subdiaphragmatic correction of air is there, which is an important cardinal sign of audiovascular perforation. In case of penetrating trauma, because the trauma might be going from the abdomen, from the thorax into the abdomen, and it might have penetrated on its way some part of the bowel, small or large bowel, and that can cause pneumoperitoneum. That means collection of air under the diaphragm. And that's about chest X-ray. That's about EFOST, that is sonogram. And another thing is CT scan. once CT scan is there with contrast, CT scan or computer tomography scan with contrast, this can potentially identify most of the cases. And this can localize what exact pathology the patient is running. Because you can ideally create a three-dimensional view, not only about the bony case, but all of the abdominal and chest cavities, they can be created, and it can potentially show what are the fractures, whether there is any contusion, whether there is any hemothorax, whether there is any pneumothorax, whether there is a combination of both, that is hemopneumothorax. And in case of penetrating trauma also, it can track the penetrating part. It can give you idea about the track. And in case of missile wounds or bullet injuries, it can give you an idea about the track and where the missile is there. So that you can, once the patient gets stabilized, you can plan elective or planned emergency elective planned therapy. So this gives you a clue. And importantly, in case of penetrating injuries also, once the diaphragm gets penetrated, yes, it is the CT scan which is going to give you a clue whether the herniation of the abdominal contents into the thorax is there or not, and if at all there is herniation of the contents, whether the contents are getting any complications or not. All these things can be known. So that's why, and previously, when I was telling something about pelvic injuries, that requires arterioembolization or angiography for its deviation. But it is the CT scan in case of thoracic aorta or mediastinal injuries, mediastinal arterial injuries, or internal mammary artery injuries, or intercostal artery injuries. All these can be made out with the CT scan in a better way, and it has replaced angiography in this case of modality. But make sure your clinical evidence should be very good, that you should not miss out a tracheal deviation. You know, a massive pneumothorax shifts the trachea to the opposite side, as well as collapsed lung, it shifts to the same side. And in your percussion, you should not miss out a normal percussion. So no, don't do that, because a posteriorly normal or anteriorly normal, you should be able to make it out, because a anteriorly normal auscultatory findings or percussion findings does not rule out injury, because an expanded lung potentially floats out from the posterior part of the hemithorax bed. So that's another important thing. And sometimes there may be herniation of the diaphragm through the diaphragm injuries from the herniation of the abdominal contents into the chest. That might be missed out. There may be practical difficulty when you put a nasogastric tube, and you may sometimes incidentally or accidentally find out on a chest X-ray that something right soup or tip of the right soup is somewhere lying in the chest compared to abdomen. That's something abnormal. In that way, it can be made out. So what ultimately is the treatment? Treatment is depends on whether it is penetrating injury or whether it is blunt injury of the chest. In case of penetrating injury of the chest, as a rule, I am telling you, in case of penetrating injury, never close the wound. Never close the wound in toto. Never close the wound in toto, unless otherwise you are very much sure that all of the blood that has been accumulated in the hemithorax of that side has been drained out totally. And that's what we call when there is sucked out wound, or when there is open wound, there will be collection in the of air or whatever blood is there in the thoracic cavity. You just don't close all of the wound. You close only three sides of the wound and put an intercostal drain as a part of the drainage at a remote site from the site of the injury. Suppose he is having the site of injury is here. We close three sides of the injury so that we make a flutter type of valve mechanism, so that if the air or fluid that makes a use of only one side of the valve, and you put the intercostal tube at a site remote from the wound, and that should be fine most of the time. And in case of blunt trauma to the chest, most of the blunt trauma to the chest, they might have torn some of the intercostal vessels, and when there is fracture of ribs, there may be occasionally internal mammary vessels might be at risk. They might be bleeding, and most of the time the bleed stops itself, and only in few cases that hardly requires a thoracotomy, so that to control the bleed. Or in case of some potential bleed, we can just simply encircle the bleeders. That's rarely mandatory. This is what's the important things about basics about treatment in case of penetrating trauma, in case of blood trauma. And of course, in case of extreme situations where there is ongoing bleeding, there might be no option other than to go for emergency department thoracotomy or anterolateral thoracotomy. That's all. If time permits, we'll conclude that in the end. So now comes the important. This is basically nutshell about thoracic injuries. But what happens exactly? What happens exactly? So let us start. Always remember this deadly dozen. There are dozen injuries that are known to occur in chest. We call them deadly dozen because 6 of them they are immediately life-threatening, and 6 of them are potentially life. And all the 6 of them, which have been detected at the time of the primary survey, they must be treated at the same time. Otherwise, they are lethal. That's why we have called them as lethal injuries, lethal complications, or deadly dozen, out of which 6 of them are lethal. First thing is airway. That means acute airway obstruction. See, I have mentioned about anything about bleeding in the root of the neck. Yes, hematoma that can compromise the airway, along with gradually progressing edema. Yes, that can compromise edema. That can compromise the airway. The airway is important. So immediately to go for intubation, because early intubation is mandatory. As goes on delaying the intubation, edema goes on increasing, and intubation will be going to be difficult for the anesthetist or for us, whoever is there at the scenario. Intubation is not impossible, it's certainly going to be difficult. And second thing is tension pneumothorax. This can be also asked as a small question for you, short question. So what is tension pneumothorax? A tension pneumothorax classically develops when there is one-way leak of the air, preferentially into the thoracic cavity rather than into the lungs. Suppose air getting sucked into the pleural space with no way of escape, That means going out. This classically happens whenever there is a penetrating injury to the abdomen or whenever there is a trauma to the abdomen. In case of penetrating injury, there will be directly an open wound, which might have sucking the air from outside to the in, equilibrating the intrathoracic atmosphere or to the external atmosphere. So preferentially air be drawn or withdrawn into the thoracic cavity with each cycle of respiration compared to the air getting drawn into the alveolar system through its tracheobronchial tree. This is what happens in penetration. And another thing is blunt injury abdomen. Most of the blunt injury abdomens are associated with contusions of the lung parenchyma, and there will be air leak from the bronchial system or alveolar system as well. So most of the times they will heal, they will stop spontaneously, and those blunt injury chest that doesn't heal spontaneously, that can lead into the pneumothorax. Third thing is sometimes it can be iatrogenic when we are trying to put a central venous catheter. That can produce pneumothorax, tension pneumothorax. And fourth and final thing is what we call MPP, that is mechanical pressure, positive pressure ventilation. This is a sort of helping giving the aid to the ventilation. All these 4 things can produce tension pneumothorax. And what happens exactly in tension pneumothorax? The picture is often dramatic. The patient will be restlessness, agitated, cyanotic. He will be tachypneic. He will be dyspneic, breathlessness, and the respiratory rate is increased. All these things leading to hypoventilation of the affected side, whether it's the right or left side. Whether of the affected side, there will be hypoventilation, and that will be rapid because of the rapid, dramatic shift of the air into the pleural cavity. The corresponding lung will be collapsed. That will be collapsed. is this, the whole air compresses this lung and the lung will be collapsed, and there will be tracheal shift to the opposite side because of the pressure effect, and there will be mediastinal shift, and there will be compression of the opposite lung as well. Opposite lung also gets compressed, and the patient will have profound hypotension. And immediate, unless otherwise the patient gets immediate treatment, you don't need to wait for even for chest X-ray to come, because this is a clinical diagnosis. And once it is diagnosed this clinical condition, you can just go for auscultation. There will be hyperresonant breath sounds will be there because of the air. And if you put your stethoscope for auscultation, I mean percussion, hyperresonant sounds will be there. Hyperresonant note will be there. And on auscultation, you can find out decreased breath sounds or absent breath sounds, technically confirm your diagnosis. And treatment is emergency basis. That is, put a wide bore cannula, preferentially more than 28 French gauge, and just with a ipsilateral, whichever side it is, the same side, you can give it in the second intercostal space. Remember, this is in the second intercostal space, anterior, or in the mid-clavicular line. You give a wide bore needle, and as early as possible, you go for intercostal drainage in the fifth intercostal space on the same side, in the anterior axillary line. In the anterior axillary line, you go for fifth intercostal space. And for whatever reason, this usually release immediately. And if it is not functioning properly, you can use for underwater drainage, intercostal space drainage with underwater drainage with somewhat of maybe 5 centimeters of water, negative suction pressure can be used, so that it will be more efficiently used, especially if it is associated with some sort of hemothorax as well. This is what happens with tension pneumothorax. This is the treatment I have mentioned. And third complication of airway obstruction is after tension pneumothorax is pericardial tamponade. Third thing is pericardial tamponade. What is pericardium? Just like lungs having pleural cavity, heart is also has pericardial cavity, and it usually occurs primarily to the penetrating as a complication to the penetrating injuries. And whenever there is bleeding into the pericardial sac is having a what we call non-distensible sac. Non-distensible sac, when whatever hemorrhage is there, and that has also got propensity to form the clot. So these two things compress the heart, and secondarily, it compresses the total vascular inflow into the chambers during the diastolic phase, and that compression of the heart, along with decreased filling in the heart chambers in the process of diastole, results in hypotension, that is decreased outflow from the heart, and this compression also reduces internal, that means the venous return to the heart. That means the central neck pressure, the central venous pressure will be more, that is CVP, central venous pressure will be more. So the neck veins will be appearing distant. So in both tension pneumothorax as well as pericardial tamponade, the CVP is raised, right? But in pericardial tamponade, the patient will be having hypotension as well. The patient will be having hypotension because of inability of the heart to supply adequate blood. The patient will be having hypotension. So all the features looking like the same. That is, distended neck veins will be there. The patient will be hypotension, cyanosed, tachypneic. There may be tachycardia. All these things. But one thing clinically is there will be muffled heart sounds in this patient, and the auscultation like hyperresonant note will not be there in case of pericardial tamponade. And you can see on auscultation, lung sounds will be normal, but only heart sounds will be muffled or decreased. So we can go for pericardiocentesis in this patient. And again, mind you, pericardiocentesis itself, there are some certain pitfalls, because there will be dry tap most of the times. As I mentioned, this is because, as I have mentioned before, there will be clot formation in the pericardial sac, and that means that means a dry tap. You get dry tap because the on both ends of the pericardia, when you are doing pericardiocentesis, on the both ends of the needle, there may not be anything there. So that we call drape tab. And the second thing is there is potential injury to the heart muscle itself. So for these reasons, pericardiocentesis is only temporary measure, temporizing measure. It's not a permanent measure. A permanent measure being only surgery or thoracotomy. By somehow they are doing right anterolateral thoracotomy or creating a small subxiphoid window and go into the space of pericardial space and evacuate that. That should be life-saving procedure to the patient. And after this, another thing is open pneumothorax. Airway obstruction, tension pneumothorax, pericardial tamponade, and fourth thing is tension open pneumothorax. Open pneumothorax, whenever the patient has open wound of more than 3 centimeters, open wound of more than 3 centimeters, or more than 2/3 diameter of the trachea, size of the trachea. The air is preferentially just what previously we have mentioned. Air will be preferentially drawn into the pleural cavity after equilibrating the intrathoracic pressure with the atmospheric pressure. We should not close the wound. We should never close the wound completely. We should use only three-sided closure using a plastic sheet, or and we put an intercostal drain and we come out. And once that is totally drained out, then we can go for complete closure. This is about open pneumothorax. And the open pneumothorax should never be converted into tension pneumothorax. And after open pneumothorax, another important complication is massive hemothorax. Pneumothorax will be there, but massive hemothorax is another dreaded complication, where instead of air, as in the case of pneumothorax, here there will be bleeding. There will be torrential bleeding once the intercostal vessels are bleed, or sometimes very rarely when there is associated with fracture ribs are there. Internal mammary vessels can get the blood accumulates into the thoracic cavity. In case of penetrating injury, some injury from the lung thoraces or from the abdominal cavity itself, some bleeding might be accumulated into the thoracic cavity. The patient will be having all the features, but here the neck veins will be flat because of exsanguinated blood. The patient will be having hypotension. So because of hypotension, the neck veins will be flat, not distended, unlike tension pneumonia. And of course, the air zones will not be there. This time, the obscurance is because of blood, not because of air. That means the note of percussion note will be done. So remaining features remain the same. And here we go for intercostal drainage. And intercostal drainage, when you first drain it, if you get more than 1500 ml of blood, or nearly 1500 or so, or more than that, or if you drain about more than 200 ml of blood every 3 to 4 hours continuously, and that is, these two are definitive indications for thoracotomy, because you cannot simply put a tamponade waiting for all the hemothorax to settle down spontaneously or by itself, because it will never happen so, because it will result into the complete ongoing bleeding. Second thing is there might be complications of MPM, and the third thing is there may be delayed complications like fibrothorax. So to prevent such complications, you cannot go for tamponade. That's what happens in hemothorax, especially when it is massive in nature. So you should completely enable to evacuate the hemothorax cavity, so that the hypoventilation, the patient comes out of the hypoventilation and lungs restore their normal function. And last but not the least, emergency complication is flail chest. Flail chest. Flail chest. This is again a life-endangering situation. Flail chest can be asked as a short question for you. This is most commonly happens in case of blunt injury to the chest, whenever there is associated fracture of the ribs, and it's classically described as fracture of more than 3 ribs at more than one side. More than one side. Usually it's 2 sides or 3 sides, maybe there will be fracture of the ribs. And this fracture of the rib, the complete fractured rib becomes unstable, and usually it is associated with underlying pulmonary contusion underlying pulmonary contusion, and the fractured rib and hypoventilated lung. Of course, you can see hypoxia from your parameters like pulse oximeter or so, and irritability, pain, restlessness, agitation, hypoxia, all these things, they are not radiological findings, just a clinical finding. Just examine his chest, and there will be inward movement of the what we call chest wall at the time of inspiration because of the pain that it produces. Instead of respiration at the time of inspiration, what happens? Chest wall goes outside. But this time it will be drawn inwards, and at the time of expiration, that will be pushing outside. So that a fractured segment is unstable. That can cause potentially hemothorax, or pneumothorax, or hemopneumothorax, and pulmonary contusions also may be progressively damaging the underlying contusions. Extensive, they may become extensive. So this failed segment as a whole causes the patient a voluntary sprinting effect, so that hypoxia goes on increasing, Okay, that means the patient is gradually, ventilation of the chest, ventilation will be decreased, leading to further hypoxia. So this is a dire emergency. And what you do is, previously we used to go for mechanical positive pressure ventilation, but nowadays we just put an intercostal tube, give him oxygen, plenty of 100% oxygen we give, along with the analgesics to the extent of opioids, because chest pain will be extremely high, excruciating chest pain will be there. And in these conditions, if patient doesn't improve, then we can consider for mechanical positive pressure ventilation, and in a few cases, of course, intubation may be necessary. And in a very few cases, where there is isolated chest fracture with the fracture segment and no other injuries, and around associated with the pulmonary contusion, they can go for internal splinting, surgery by means of internal splinting. And these are potentially life endangering situations. And I think we are running short of time. So, what are the other complications? The less dangerous but potentially life-threatening complications. There may be rupture of thoracic aorta first. There may be rupture of thoracic aorta. There may be tracheobronchial injuries. Number 2. And number 3, there may be myocardial vent injuries. Number 4, there may be diaphragmatic injuries. Number 5, there may be esophageal injuries. Number 6, there may be the pulmonary contusions. All these 6 things are potentially life-threatening. We will discuss at some point of time later. And after this, you can cure these things. You should be able to think about emergency department thoracotomy if it is necessary, because these things are classically described as an armamentarium of the general surgeon or a cardiothoracic vascular surgeon. Wherever there is acute bleeding, uncontrollable air leak, or uncontrollable bleeding coming from the anterior mediastinum and mediastinum, and each time the heart has to be approached carefully. And in case of, as far as general surgeon, vicinity of the general surgeon is concerned, it is extremely difficult. So you can go for anterolateral thoracotomies on both sides of right side as well as left side, and we combine both the incision. That's what we call clamshell incision, to approach the heart for a preferably untrained general surgeon in case of emergency. If you want to approach left anterolateral thoracotomy, you can see left side of the heart. You can see left lung, left hilum, and lower part of the esophagus. These vessels and the arch of the aorta, these things can be repaired. On the right side of the right anterolateral thoracotomy, you can repair esophagus vein or superior vena cava, infracardiac part of the inferior vena cava, and right hilum and the right lung, and of course middle part of the esophagus and upper part of the esophagus, and tracheal portion. Thoracic part of the tracheal portion, or we call it a thoracic trachea. And both these things can be done at the same time. And at the time of sternotomy, the other process, sternotomy means splitting open of the sternum, and that is essentially for repairing of the heart or anterior mediastinal structures, or ascending arch of the aorta, descending and arch of the aorta up to the subclavian artery. This will give an excellent exposure, along with the carina part of the trachea as well. These things can be managed with sternotomy, but with a little hope. When the patient is gone for an emergency surgery on these grounds, that gives a little hope of cure for the patient. And finally, you go through uh, once whatever. I think you are tired now, but you go through these complications, and this is a potential long question for you, and you are free to ask your questions. Girish, just hold on 1 second. Girish, when I come next time, I will come with slides and everything because I'm not prepared yet. For just a couple of classes, it will be difficult for me because I have been never exposed to virtual classes like this. Not only myself, but the whole department and all of the teachers as well. Okay. Uh, if you can feel free to ask any questions. Have I gone through the too much pace? And am I audible or not? You can type any queries or any suggestions in the chat box that will be shown to me by our technician. Open this. If I'm audible to you, please give me your feedback. For 1 or 2 classes, you should cope with us. The chat box is open. Yes, someone has asked what if there is clot occlusion. Clot occlusion in the tube is a common phenomena, not a very rare phenomena. There are two options. One thing is you have to open the intercostal tube and put a negative pressure more. Second thing is sometimes you have to change the second drain. There is no option. No, obviously it comes as DCS only. Whatever emergency procedure we are trying to do in the patient. That's why clearly I have mentioned in the end that gives in case of penetrating trauma to the chest, DCS results will be somewhat optimal. And because of lack of time, I couldn't tell you whenever the blood pressure in case of penetrating trauma at the time of damage controlled resuscitation, if it is more than 60 millimeters of mercury, chances of survival by through means of DCS are more than 60%. If BP is more than 40 millimeters of mercury, chances of very much dismal less than 30%. And if BP is less than 40 millimeters of mercury, chances of survival are less than 3%. So all these procedures, they come as DCS only. Not as that will never can be claimed as elective trauma. I think I am pretty clear with this doubt. Anybody? So that's why when we are doing planned thoracotomy, results will be, of course, somewhat expected. And in case of blunt trauma to the chest, almost always chances are dismal. And finally, to conclude, chances are always futile, chances are always dismal when already CPR has been done, when CPR has been attempted, and that's not successful. And there are no chances of life in case of blunt trauma abdomen. Hardly there have ever been case reports. And secondly, when there had been CPR was applied for constant 5 minutes without intubation, or when the CPR has been done for more than 10 minutes with intubation, and as I mentioned, in case of blunt trauma to the chest, all these three things give you futile results. They are very poor prognostic. Yes, any more? I think I'm in a bit hurry and a bit confusion mode. But next time, I think I will come up with good. Has asked what is trauma transfusion protocol? Yes, what trauma you want? I am speaking something about polytrauma, which has to be combined by just because we are dealing with chest injuries. It may be neurosurgeon may be required, cardiothoracic surgeon may be required, and orthopedician may be required, and general surgeon for a point of laparotomy may be required, and skeletal injuries may be there. And again, some subspecialty of orthopedician may be required, and vascular surgeon may be required as a part of DCS when you are trying to uh, go for vascular repairs. So sometimes plastic surgeon may be required, acromioclavicular fracture or posterior dislocation. So the sort might be dealing with the orthopedician and plastic surgeon might be required. And depending on the trauma protocol, it always depends on the trace, what we call the trace system. What trauma we are dealing with. What trauma we are dealing with, that depends on trauma transfusion protocol. Somebody had mentioned. Can deadly doesn't occur in a sequence? Yes, deadly doesn't, they never occur in a sequence. We call it deadly dozen, but out of them, half dozen are really deadly. Half a dozen, which I have just mentioned, but not mentioned in depth because of lack of time, they are potentially life threatening. They never occur in sequence. One common thing is hemopneumothorax that can be occurring, but tension pneumothorax is a separate entity that is a drastic thing. But pneumothorax is a drastic thing. But hemopneumothorax is in a combination, it's not that much dangerous. It gives you some time. By hook or crook, you can come out of this situation. I think remaining things you can study at home, and remaining any questions, I will be able to answer you in the next session. Any more? So wish you all the best. I'm closing my topic with this, and probably next Wednesday, accordingly as I have been allotted, I'll be coming in touch with you. Wish you all the best, and thank you very much.